everyone, and welcome to this ODC webinar on organizing for better care. I'm Daniele Mascia from Luis University, and I'm glad for having the opportunity to contribute to the Organizing for Good campaign, an initiative developed in joint collaboration with the United Nations Refugees Agency. So let me start by expressing my gratitude to the ODC community for inviting me to organize this webinar. A special thanks to Francesca Pallotti. Ciao Francesca. Francesca is a co-author and a colleague of mine based in Greenwich University. She will help me to moderate our discussion. But special thanks to our two guest speakers of our webinar today, Professor Jody Gittel and Dr. Kelly Vranas. So thank you very much for your contribution to this webinar, and very look forward to hearing from you. So let me. Okay, so I think.
Yeah, I'll say a few words as well. So good afternoon, everyone, and welcome to this webinar. So the objective of the webinar today is to share ideas and encourage discussion around the topics of organizational change and resilience in healthcare. And as Borge was saying at the beginning of this meeting, this is more than ever a current topic. So the COVID-19 pandemic, which has been defined or can be defined as a low chance, high impact event, requires healthcare systems, but also the organizations working within them to react and to maintain organizational resilience in order to respond effectively to such events. And so the topics that the two talks from Professor Gittel, from Dr. Vranas will actually cover the following topics. So the interplay between organizational structures and networks of relationships in the context of change, the effect of coordination on patient care, organizational responses to uncertainty and risk. So how do organizations react and respond to uncertainty? And finally, the impact of organizational processes on patient and organizational outcomes in critical care. So, Daniele, if you can move to the next slide, please. So the two speakers, as Daniele said, are today, and we are very pleased and honored to have them with us, are Professor Gittel, Professor of Management at the Heller School for Social Policy and Management, and Dr. Vranas, an assistant professor of medicine, Division of Pulmonary Critical Care Medicine, School of Medicine, at the OHSU. And the two speakers will present and represent the two different but complementary perspectives on organizational change and resilience in the context of healthcare. So the first talk from Professor Gittel is more organizational, focusing more on organizational level outcomes. The second talk is more clinical, focusing more on patient level outcomes. So we hope that together that will stimulate the discussion on how these two perspectives may inform and complement each other in practice, and how both patients as well as organizations may be able to benefit from the integration of these two perspectives. So without any further ado, I now leave the floor to Jody, who will be our first speaker today. And I would kindly ask the courtesy to hold your questions until the end of both talks, so that we can have a broader discussion involving both speakers together at the end of the second presentation. So thank you, and Jody, the floor is yours.
Thank you so much, Francesca. It's an honor to be with this community on your anniversary, and appreciate both of you and Danielle for inviting me and Kelly to share about our work. Even though we're holding questions to the end, we're really eager to learn from you. So please add things in the chat as we go. And that will help to get the conversation started. Yeah, I wanted to start with the challenges that I think we're facing. It's pretty obvious. I think we're living in a highly interdependent world, and it's wonderful to be with this global community today for that reason. We're interdependent, I think, socially, economically, environmentally, probably physically interdependent, as we just learned with the rapid spread of this COVID-19. Evolutionarily, I think we're interdependent, and even emotionally, as events in one part of the world tend to impact emotions around the world. And the challenges that we face as a result are increasingly complex and often global in nature as a result. And healthcare leaders, as well as other leaders, are learning to recognize and manage this interdependence. And I do think it's going to be a critical skill going forward for leaders to both lead and design for this interdependence. And I'm going to argue basically that relationships are essential for managing this interdependence. So my first study in this area was in airlines, where I noticed probably in my first couple of days in the field visiting airlines, that there was basically a network that didn't always work very well, of different roles involved in the work process called flight departures. And yeah, there was a lot of insights from talking with people in each part of the network and seeing how dependent they were on others, but that wasn't always recognized. And it certainly, the design of the organization did not facilitate the management of that interdependence. And I came away with the hypothesis, first of all, that relationships actually are shaping the communication through which coordination occurs. And that sometimes happens in this way, where in each of those 12 different roles, people have a sense of their separate goals, but also their shared goals. They understand each other's work, and they respect each other's work, and they have sufficiently frequent, timely, accurate problem solving, high quality communication, basically. But I also saw much more of this, where people were locked into their functional goals. They had very deep knowledge, but it was fairly exclusive to their role, and they weren't able to see the larger system. They didn't have systems thinking, and a perceived lack of respect for their work. And the communication was often insufficiently frequent, delayed, inaccurate, and when problems occurred, which they naturally will, it tended to devolve to finger pointing rather than problem solving. So I called that relational coordination. It's basically a dynamic process of communicating and relating for the purpose of task integration. And ideally, it's reciprocal between the roles, so that people are meeting each other's needs, and it's not just all going toward the higher status roles. So I investigated the performance effects of this network of relationships, and found, just a brief scatter plot of the findings across the 9 sites that I studied, that quality and efficiency performance were significantly impacted by the strength of those networks at the site level. And within any given airline, you could see pretty dramatic differences depending on which site. So it suggests that there's some local design features that are shaping those networks, and it's not just the entire organization doing things uniformly. And I think when Kelly talks about, critical care, there definitely are differences within hospitals of which unit is coordinating really well, and maybe right down the hall, one that is not. So there's some local design issues to look at, as well as global. And I did move very quickly from this into healthcare. I happened to be having my first baby, and this became very interesting to me as well. How is this happening here, where it really literally is life and death? That can be true in airlines, but certainly on a moment-to-moment basis, there are higher probabilities of something going wrong in healthcare. So I became quite interested in how this is handled, and how to understand and connect across these silos. So I did a 9-hospital study of surgical patients and so on, and measured these networks again, and found that across these hospitals, in this case, it was Boston, New York, and Dallas, very high performing hospitals, high volume in this particular surgery. There's a lot of variation, even in this high performing group, in their quality and efficiency. and the relational coordination explain quite a bit of that, in addition to the patient, risk factors that you would expect. And so I wrote about that in these two books, that in addition to peer-reviewed articles, because I do like having a broader conversation about important issues like coordination and organizational performance. And the research has continued into a lot of different areas. A lot of it has been in healthcare. It's like healthcare is not an industry, it's a sector. There's so many different things going on in the same sector that can't be generalized necessarily, but people are also exploring these issues in commercial, health, human services, and education sectors. And around the world, which has been fun to watch. In a systematic review, we found that this research is happening just like the community that we're part of today, really in a global, has a global scope. And so some of the performance outcomes that people have been tracking of these organizational networks of relational coordination are quality and safety, which I had looked at, some efficiency outcomes, which I had looked at, but also things like client engagement. Is it easier to partner and co-produce with your client when you are experiencing high levels of, you've been able to create high levels of relational coordination among providers? And it turns out that's the case, that by learning how to partner better with each other, it's also easier to turn around then and partner with the client. And in so many of the healthcare contexts and even other organizational contexts, if you are just delivering to the client rather than engaging them actively in the process, the outcomes are not as sustainable. So that ability to use these networks to also engage with the client, I believe, has increasing applicability going forward as we talk about co-production. And of course, worker well-being, that's another sustainability factor. We're not going to have these quality and safety and efficiency outcomes for very long if we're not also attending to the well-being of workers. And I was very not surprised, based on my qualitative interviews, to find that relational coordination is quite highly predictive of worker well-being. When people have their coordination needs met in terms of they're getting timely communication, accurate communication, people are respecting their work, they have a sense of shared purpose, people understand their work, it's gratifying, it leads to higher satisfaction and lower burnout. And I think it's also, there's a lot of evidence that positive relationships are intrinsically or even rewarding, as well as being instrumentally rewarding. And then finally, learning and innovation appears to be more possible when people have the big picture and can see the system and not just their own little piece of the system. There are more opportunities for breakthrough innovation. So this is just summarizing the argument about RC and worker well-being. Less wasted effort, less stress, more respect, and so on. And we do see increased retention when the levels of relational coordination are high. And then, of course, this idea that when you have these broader relationships across functions, that is the kind of culture that Deming described as being the culture of a learning organization, that you're able to see opportunities for improvement and actually act on them because you're not just locked in your own silo. So that, I think these networks of relationships are really powerful and important in organizations to achieve outcomes for almost every stakeholder. So I think that's one reason that we're drawn to them, because they do create some win-win opportunities if we can build them. So then comes the question of how do we build them? And I will, before getting into how we build them, I'm going to talk about how important they are for resilience under major pressures. So I've basically been studying this, and many people have been studying the importance of networks for performance under kind of everyday stresses and strains. Like we have, a major storm that might be shutting down the air travel. There are things that have, in a sense, challenges every day that are due to uncertainty, interdependence, and time constraints. And those are the conditions under which these networked relational forms of coordination are expected to work really well. But what happens when you get to the level of a major crisis? where you're really looking at the need for resilience in a way that goes beyond your day-to-day need for resilience. So there is a lot of evidence, as we know, that people and organizations can be resilient under pressure. And so one of the questions I really like to ask is, how can organizations increase the capacity for handling those external pressures effectively? What's the role of relationships, and what's the role of structures? So I did study this in the context of managed care, because in the US, because we had been on a different kind of payment model, as we moved to managed care, there was a lot of stress and strain in the healthcare system. How are we going to do this? How can we possibly meet the needs of our patients with these kinds of limitations on the resources that we are able to use? So it was a crisis of sorts that played out differently across the US. So I used that to study. And we know from social psychology that individuals can respond to external pressure or to stressors through coping mechanisms, both individual and collective coping mechanisms, like self-efficacy or collective efficacy. And by that, coping mechanism can interrupt the flow from a stressor to the felt stress, and therefore protect you from performance decline. And from organization design theory, I'm not listing all the relevant theorists here, but there's also this sense that an external threat can lead to performance decline, but that organizational structures can provide support that helps to interrupt that impact and therefore provide some kind of resilience. And I tried to basically combine those two, the individual level and the organizational level, and test this model where the degree of managed care penetration in your local market will increase your work stressors and possibly evoke a collective coping response. But what is the role of your formal organizational structures in helping to support that? And these were the findings, that the impact of felt stress on collective coping, measured as relational coordination networks, was significant, but the bigger impact, and I think more significant for sustaining over time, is, do you have relational structures that help to support those networks of response? So basically, I think the story is that the relationships provide resilience, but the structures are needed to sustain it and support it over time. So these are the structures that have been studied and shown to predict relational coordination. It's basically taking a lot of our everyday organizational design features and practices and designing them to connect across the work groups that are involved in a shared work process. So if you think about that map might, that relational network map, that might represent 10 or 12 functions that are involved in carrying out an important work process. It could be the success of our organization, could be managing patients in the ICU. It could be a cross-organizational process, as we'll see. But then the question is, how do we redesign each of these structures to better support shared goals, shared knowledge, mutual respect, frequent, timely, accurate problem-solving communication across those roles that need to collaborate in order to achieve the desired performance outcomes? And there's a lot of fascinating work here, I think, about relational job design, about developing systems of shared accountability and rewards, conflict resolution processes that connect across the relevant players and not just, you take the doctors, I'll take the nurses. And so I think that's where a lot of the richness is right now, is figuring out in real life how to design and implement and carry out structures that can support this collaborative process. And I'm arguing it's helpful to build that before a crisis, because in the middle of a crisis, you can put things together, you can definitely get through it, but it's helpful before. And I point to Ingrid Nembard, Larry Burns, and Steve Shortell, and a recent piece that they published called Responded to COVID-19, Lessons from Management Research. And I recommend it. Okay, my neighbor's here. Thank you. Yes. this idea that you require a coordinated response amidst uncertainty by teams that cross multiple functions and roles. And that's true in everyday life, but it's especially true during a crisis. And many of those caregivers or functions likely have either not previously worked together or have not worked together under complex conditions, the circumstances when relational coordination matters most. So that's why it can be helpful to have structures ahead of time. Although there are structures that will emerge during a crisis that can then be considered for continued functioning, because sometimes you don't know until a crisis happens who actually needs to coordinate with who and what are the best ways to do it. So it is a dynamic process. But going back to, so this question now is, how do you prepare your organization to respond with resilience? People have started to take this, this theory and turn it into a model of change. And I think that is a helpful thing to think about, because when I first studied organization design, it was more of a, it wasn't clear who was designing what. It was kind of like organizations get designed and they have these consequences, but the process of designing and redesigning when I was a doctoral student was not so evident. And a lot of my early work was going out and telling people, yeah, design things this way, and then these networks will tend to develop and you'll get these outcomes. And people would say, great, where do we start? And I'd say, I have no idea. I do not know, because I hadn't learned that through organization design. So this organizational change perspective, I think, has been very rich for the field of organizational design. And I'm hoping that, that to learn more and more about where the field is going in terms of creating and redesigning structures to be more resilient and under both normal and crisis conditions. So the idea being that we need to transform from more competitive to collaborative relationships, but it's not just your typical design challenge, because it's not just about the structures, it's also about the relationships. And our relationships are very influenced by our identities that are deeply embedded. And as one doctor told me, it's etched into our psyches, what it means to be a doctor. So these don't change just by creating new structures. It requires the participants to question current assumptions about themselves and others, and possibly, I hypothesize, to have a safe space for doing this, and then engage in this design process. So we're going from these more competitive relationships to more collaborative relationships, and that somehow has to be part of the design and redesign process. So what does that look like? I have taken these things that were called organizational structures. I now call them structural interventions, to kind of remind us that they actually are interventions. They can be designed and redesigned, and every time they really are either an intentional or unintentional intervention. But we also may need relational interventions that involve creating psychological safety, engaging in humble inquiry, mapping and measuring relationships to understand our current state, and then identify our desired state and experiment to close the gap. So we're really bringing, in addition to traditional organization design, bringing in some of the knowledge from colleagues. Like, I developed this model in conversations with Ed Schein and Amy Edmondson, who really are moving toward these notions of psych safety and humble inquiry. And I think they can make a very nice partnership with org design. So moving on, so this model is laid out mostly with case studies and examples of these interventions and what they look like when I go into the field, because some of my colleagues have really gone beyond where the theory was, and they've turning the theory into practice, and that's a wonderful way to learn. So this is one of those colleagues, Dr. Tony Suchman, relationship-centered healthcare, who was a practicing physician for most of his adult life and then became a consultant, but basically trains people in these 6 stages of change: explore the context, introduce the concepts, create a change team that represents the different parties in the work process, maybe someone from each of those 12 groups, assess RC, reflect on the findings, design interventions, that are informed by what you found about the current state of relationships, but also the lived experience of you and your colleagues in each of the stakeholder groups that are involving, and then, of course, implement and assess. So it's not so different from a process improvement methodology, but in this case, the process improvement is focused on how our collaborative capacity itself. And so here's an example. This is from Australia, a top management team mapping out the relationships around the, I think it was the scheduling of the operator of the surgical rooms, and seeing where we have big challenges and where we have strong ties. And even this was a big aha. I remember the CEO saying, you know, shouldn't that line between those anesthesiologists and surgeons, shouldn't that be green? And they're like, yes, but it's not. And so being able to visualize and see where some of your challenges might be and some of your risk factors going forward can be very helpful. And then you can also measure it with a more inclusive kind of process that involves people completing a survey from maybe hundreds of people in the same work process. And then saying, okay, what really is going on here? And why is it that way? And how could that be better? And looking at how we're doing on each of those dimensions. And what is timely communication for you in your part of the work process? And how could we create more kind? So you get some brainstorming that can start to develop design solutions based on data. But I'm also going to argue briefly that you can go system-wide. And we need to go system-wide to address social determinants of health. You know, the core of the health system, which still tends to be the hospital, is very important, but as we know, it's not enough. We need a broader array of partners throughout the community to achieve health and wellness. So I'll just kind of end with that, where you can do this same process, relational mapping for healthy communities. This is out in San Francisco, where they were addressing the goal of achieving high quality mental health care for San Francisco by 2030. And so they were addressing like the health system delivery, the payers, the patient social determinants, and so on. So again, you can use this process to start seeing where are the networks strong and where are they not. And then you can actually measure that and see, well, when you're going across organizations, initially, many of them will be weak because we tend to be even less collaborative across organizations, at least in my experience, than we are within organizations. And so there are a lot of opportunities for us to build high quality, resilient health systems that involve many community partners. And that's one thing we're trying to do with this project. It's called Building a Relational Society, Local Action for Global Solutions. And you'll see we're trying to, everything I've talked about is mostly at this meso level of coordinated collective action, but there's also an institutional context that needs to be addressed from a policy standpoint. And then what is happening at that micro level of, human connection and how to support that. And that has just come out in a book called Social Scientists Confronting Global Crises, which I think will be interesting for this community as well. And one of the communities, it's not as comprehensive in any way as this organization design community, but the Relational Coordination Collaborative has been a nice global community to bring together researchers, leaders, and change agents to basically develop solutions. And as you know, we never, as researchers, we don't ever want to just be talking with ourselves because we don't have, and we really need to partner with people who are experimenting every day with innovation in the workplace as practitioners. And, I consider myself both a scholar and a practitioner, and I'm honored to hand off to Kelly, who is also both a scholar and a practitioner. And so thank you so much for your attention. And Kelly, can hardly wait to hear your stories and your findings.
Kelly? Oh.
Can you hear me?
Yes, we can.
Okay. you see the big, the large screen. You can see my slides. Okay, wonderful. Thank you so much. So I am Kelly Varanis. I'm an assistant professor of medicine at Oregon Health and Science University in Portland, Oregon, which is OHSU for short. And I'm a practicing pulmonary and critical care physician, as well as being a critical care health services researcher. And I also spend a lot of time at the Portland Veterans Affairs Medical Center. So I'm really thrilled to be here with you today. I'm really grateful for the opportunity. My plan today is really to discuss methods to improve the value of ICU care through organizational innovations, but with a real focus on the current pandemic that we're living through. Mine's going to be a much more clinical focus, but hopefully complementary to Jody's talk. I don't have any relevant disclosures. And here's the outline for my talk today. So I'm going to start by discussing the evolution of critical care as an organizational innovation in and of itself. I'll then review some organizational drivers of high-value critical care, followed by a discussion of how strain on the healthcare system impacts and threatens the organizational structures within critical care that we've developed over the last 20, 30 years. And as part of the discussion, I'm going to discuss some results of a recent study that I've led, really trying to understand how strain from the pandemic has influenced the experiences of frontline clinicians, as well as the organization of our critical care delivery system. So just to go back a little bit, so hospitals have existed for most of recorded time, but it really wasn't until the Crimean War of the 1850s that hospitals began to take their modern form. So this change was really pioneered by the legendary nurse Florence Nightingale, who's shown here. Among her many innovations was to kind of gather the hospitalized soldiers who were the most ill, the most wounded, who had the greatest injuries, and she brought them to a central area around the nursing station where they could be carefully observed. And in this way, she really created our first model of what critical care has become today. And over time, this concept has evolved into the creation of specialized units called the ICU, or intensive care units. And this is really where we provide care for the sickest patients in the hospital who are at really high risk of dying and who often need invasive life support to survive. And really this notion that we group patients not by their underlying diagnosis, but rather by their severity of illness, really allows hospitals to take advantage of economies of scope and scale within healthcare. And in this way, the creation of the ICU really is an organizational innovation. So these pictures are just showing you what a typical ICU looks like today. So the picture on the left, you see the nurses station in the center with some chairs and computers. And across the hall, you see the individual patient rooms that are typically have sliding glass doors so that the staff can see and react quickly if anything acute happens for patients that requires prompt attention. And then on the right is an inside of an ICU room that's pretty typical. You can actually, what I just want you to make note of is that it's big. It has a lot of space in there because we need a lot of equipment to take care of patients who require life-sustaining treatment. And this is what it looks like when someone's in that bed. So I just wanted to give you a sense of kind of what my day-to-day clinical experience is like. On the left here, you see the IV pole with a lot of different pumps on it, and those pumps provide life-saving medications for patients like antibiotics and blood support medications. And on the right here is a mechanical ventilator. That is a machine that we use to actually breathe for patients who have respiratory failure and who are not able to sustain appropriate oxygen levels on their own. And that mechanical ventilator is attached to the patient through tubing that goes through their mouth into their lungs and does the breathing for them. And really the purpose of these support medications and devices is to just support the patient and give their body time to heal from the underlying disease. Unfortunately, we know that critically ill patients are at high risk of death. So mortality for critical illness syndromes such as respiratory failure requiring mechanical ventilation, or things like sepsis, which is really overwhelming infection of the body, mortality for those conditions ranges anywhere from 25 to 50%. And for those patients who survive, we know that nearly 60% of ICU survivors actually experience physical, mental, or neurocognitive disorders that can really negatively impact their functioning and quality of life for months or even years after their hospitalization. And additionally, it's now recognized that psychological distress is really common among family members of patients who unfortunately are in the ICU as well. And these symptoms include anxiety, depression, and post-traumatic stress disorder. Importantly, it's also notable that outcomes vary widely across hospitals. So Jody got to this a little bit, but really where you're admitted matters. So for example, several studies have shown a relationship between hospital volume, so the number of patients a hospital cares for in a given year who have certain conditions. So if patients get admitted to a highly experienced hospital who's used to taking care of patients, that can actually reduce your odds of dying by anywhere from 25 to 50% compared to lower volume hospitals with less experience caring for certain conditions. And what's important to note is that why is this happening? Why do outcomes vary so much between hospitals? And I think that variation really represents an important opportunity to improve outcomes for patients with critical illness. So as a critical care health services researcher, I really want to understand why that happens, why hospitals perform better than others. And I think by identifying underlying organizational structures and processes of care that lead to better patient outcomes, we can then disseminate that knowledge and give us opportunity to improve outcomes across a broader variety of healthcare settings. Finally, because ICU care is very resource intensive and labor intensive, it's very expensive. So across the world, ICU care, no matter where you are, it's quite expensive. But in the US in particular, with our aging population, we are using ICU more and more. So for example, between 2000 and 2010, costs in the United States increased from $57 billion up to $108 billion. So that was an increase of about 92% over a 10-year period in our critical care costs. And for us here, that approaches nearly 1% of our gross domestic product. But it's not unique. Critical care is expensive everywhere. And so with that in mind, as a critical care health services researcher, my focus is really on developing, testing, and implementing organizational interventions and processes of care that improve outcomes, but also the overall value of critical care, which for the purposes of my research, I define as patient outcomes or quality of care over cost. Okay, so pivoting a little bit, I want to review some organizational drivers of high-value critical care that we've identified through health services research over the last 10 or 20 years. So recent literature has really identified a variety of these evidence-based practices that include both organizational structures, which we could define as conditions under which patient care is delivered, as well as processes of care, which can be defined as activities that constitute actual patient care. And these factors can directly influence clinical outcomes and are therefore really important platforms for care improvements. So here are some examples of some organizational and process interventions that have been associated with high-value ICU care. I'll just briefly walk through these. So the first example I want to give you is ICU physician staffing. So ICU physicians are like me. They're physicians who've been specifically trained in the care of critically ill patients, as opposed to general physicians who do not have that extra specialized training. We're also called intensivists, if you hear me say that, but I'll try to stick with ICU physician. So there was this has been studied quite a bit, and most recently, a systematic review found that having an ICU physician involved in the care of all ICU patients actually decreased the odds of dying in the hospital by nearly 20%, as compared to critically ill patients being cared for generalists who do not have that specialized training. Additionally, we know that the number of patients assigned to staff matters. So generally speaking, in the United States, in the ICU, it differs by state, but most states have laws that require no more than 2 ICU patients per nurse, with the thought being that more patients assigned per nurse will lead to worse outcomes because these patients are really sick and need a lot of attention. Similarly, there was some recent data out of the UK that defined the number of patient to physician ratio as being about 8. So that once, if the number exceeded 8, like the higher the number of patients over that sweet spot of 8, the worse outcomes patients had when looking at patient to physician ratio. And this is just an example, again, of a modern day ICU, what most of them look like now, where there's this little pod station in between 2 rooms with windows into the rooms. And this is where the nurses sit. So usually there's one nurse with 2 rooms, and he or she can actively, keep an eye on and be able to react quickly if the patient needs something. Notably, daily team communication strategies are process factors that have been associated with lower mortality across ICUs. So these include the use of multidisciplinary rounds. So rounds is what we do every day when we take care of patients. We meet in the hospital and we round on patients, which means we go from patient room to patient room and develop a plan for the day. So in the ICU, we've seen that involving interprofessionals in this process improves outcomes. So that can include not only physicians and nurses, but respiratory therapists, clinical pharmacists, even nutritionists. So this is an example of what daily rounds in the ICU looks like. This is actually the hospital where I did residency at the University of Pennsylvania. And that's outside the patient's ICU room. You see nurses, physicians, pharmacists all gathered together. And step by step, we talk through what happened over the last 24 hours and come up with a plan for that day. And again, this process in and of itself is associated with improved survival for critically ill patients. And finally, as I mentioned earlier, we know that family members of those hospitalized with critical illness experience a lot of psychological distress related to both seeing their loved ones very ill, as well as having to serve as surrogate decision makers when patients are too sick to be able to make decisions on their own. And that can place a lot of additional burden on family members, in addition to the grief they're already experiencing. And so there's actually been several strategies identified from an organizational standpoint that improve long-term family outcomes. And those include involving family in the rounding process, having them present in the ICU, as well as routine and structured communication strategies to provide updates to families about the status of their loved ones. And this is an example of what that might look like. So this was a tweet by Dr. Greg Martin, who is now the Society of Critical Care Medicine's president and a practicing ICU physician at Emory University in Atlanta. And this is just a picture of what multidisciplinary rounds look like at the bedside. You can see the family of the patient surrounded by the huge team. It is a lot of people, but they are rounding on the patient here. And again, this strategy has improved outcomes for family members as well. Obviously, this picture was taken before COVID. And finally, we've talked a lot about things we can do, but there's also it's also important to recognize that sometimes we need to de-implement or stop doing things that we now know to not be beneficial for patients. So I just wanted to point that out, that it's very important in healthcare in general that more is not always better. Okay, so we've discussed several organizational factors and processes of care that are associated with high value, high quality care. But I'm also really interested in how strain on our healthcare system influences the organization and our ability to adhere to these evidence-based strategies that we know improve outcomes. And obviously that's been brought into sharp focus by the COVID-19 pandemic. So specifically, I want to understand how the pandemic has influenced these organizational practices that we know improve the quality of care. And that brings me to the last part of my talk, in which I'm going to discuss some research I've been conducting. First, though, I want to define healthcare capacity strain. For those of you who may not be familiar with this term, this has been defined as threats to the ability of a care team to provide high quality care to all those who need it on a given day. And I think it's really helpful to think of hospitals and even ICUs as balloons, so able to accommodate increasing strain or pressure up to a certain point, after which outcomes deteriorate and the balloons pop. So in my opinion, this is one of the key questions we need to try to answer, is what makes some ICUs or hospitals more elastic or resilient in the setting of strain. Healthcare strain can occur due to numerous both patient level and system level factors, but I think it's easiest to kind of summarize those factors into one of each of these four buckets. So the first is increased patient volume, so just a larger number of patients than we're normally used to seeing. The second is increased severity of illness. The third is special care requirements, such as the need for personal protective equipment or PPE. And the fourth reason for strain is resource reduction, which can happen, for example, in the setting of disrupted supply chain. And so you can see here that the COVID-19 pandemic has impacted every single one of these buckets, clearly causing tremendous strain on our healthcare systems worldwide and threatening our ability to provide that high quality care to those who need it. When thinking about how to best prepare for crises like this, there's something called the 4S framework that is classically used for hospital emergency preparedness responses. So just to briefly review that, the first S in this framework is space, which is referring to the physical capacity or physical spaces for patient care, so number of beds. The second S is stuff, which refers to the physical equipment required to deliver care and support care delivery. The third S is system, which refers to the planning and leadership required to operationalize a response effort. And the fourth S is staff, referring to the personnel both involved in direct patient care as well as those involved in hospital operations. Yet few data really exist to guide us when we're trying to think about how to organize critical care in the setting of a pandemic, especially when it doesn't happen that often. It seems like we reinvent the wheel every time. We also don't really know what works well and what works less well as perceived by people working on the front line and looking at actual numbers as far as patient outcomes. So again, given my interest in healthcare strain and how it influences outcomes, over the last several months, really a year and a half now, I've been working to try to address some of these questions using both quantitative and qualitative methods across a variety of healthcare systems that are really focused in the US, but I think there's some lessons to be learned and extrapolated more broadly. So for the remainder of the talk, I'm going to share with you the results of a qualitative study we've just completed. So in this qualitative study, we interviewed ICU physicians specifically across a variety of hospitals in the United States that experienced early and large surges of patients with COVID-19. We really wanted to get a deeper understanding of their experiences of the pandemic, including their perceptions of what hospital responses worked well and what worked less well. Let's see, our interview framework was organized around that 4S framework that I just described. And overall, not surprisingly, we found that the pandemic really did threaten our ICU organizational structures that we built over the last many years, and our ability to adhere to some of the evidence-based practices I described earlier. Simultaneously, the pandemic has created substantial moral distress and symptoms of burnout across frontline clinicians, which I think we know, but I'm going to go into a little bit more detail on that. And we also importantly identified some key interventions at the systems level that at least were perceived to both improve patient outcomes and reduce burnout symptoms and improve resilience among the frontline physicians. So I'm going to share that with you now. Under the first category of space, we found that all hospitals canceled surgeries early on, elective surgeries, I should say. So those are things that you plan for and schedule, like a knee replacement, or even sometimes heart surgeries, but things that are not emergent. So all hospitals early on canceled these elective surgeries in an effort to improve capacity and decrease strain on the physicians and the nurses at the front line. And largely, the ICU physicians we interviewed felt this was really helpful. However, there's a downside or unintended consequences to this, and that is delaying care for patients who don't have COVID, but who need routine health care. And that can lead to worse outcomes down the road. And then particularly in the United States, given our payment model, this led to substantial financial losses for hospitals. As hospitals resumed surgeries during the summer and fall of 2020, they looked back and said, we can't do that again. So all hospitals, since at least that we interviewed in the US, have continued surgeries despite the subsequent multiple surges we've seen over the last 12 months or so. And intensivists perceived the decision to continue surgeries throughout subsequent surges as really threatening. It really caused increased strain and actually compromised their trust in their institutions due to the perception that hospitals were actually prioritizing finances over patient and staff well-being. So for example, one ICU physician that we interviewed said that continuing with elective surgery during the second go-round, meaning the second surge, was probably not the best thing because we had such a high surge going on. And they went on to say, people outside our department did not realize how stretched thin we were. I feel like we should have fought more to shut down the number of surgeries that was happening. As I mentioned, some ICU physicians felt that financial losses drove these policy decisions and that was irresponsible. So this physician said, we've all doubled our clinical effort already at a time when we are at 100% capacity, and they are talking about doing elective knee replacements. That is wildly irresponsible, in my opinion. Shifting to the second S of stuff, we found that early on in the pandemic, when transmissibility and things about the virus were not well understood, masks were not widely used in the United States, at least. And in fact, the hospitals actively told people not to wear masks outside patient rooms because they didn't want to scare people, or maybe they were short on PPE. But regardless, physicians wanted to, and they often felt shamed for doing so early in the pandemic. PPE shortages were also very widespread, and that led to reuse of items that were designed to be for single use only. And that led to a lot of anxiety and fear among healthcare workers, as well as substantial distrust towards their institutions that hospitals were not prioritizing the safety of their frontline. In addition, training on how to use that PPE was really variable. Some physicians at hospitals didn't get any training at all. Some got some online videos to watch, and others got actual hands-on training. And the ones who received that hands-on training felt that it was really helpful and actually decreased their anxiety. The ones who didn't get that training really wished that they had. So just some illustrative quotes. So this quote illustrates, again, how some physicians felt ridiculed for wearing a mask early on in the pandemic. So specifically, this physician stated that when the pandemic started, clinicians would get in trouble for wearing a mask outside a patient's room, and that staff were explicitly told not to wear masks around the hospital. They went on to say that the administration said, if you want to wear a mask all the time, you have to bring your own. It was almost like they were shaming you for wanting to wear a mask. This quote illustrates how distrust experienced by physicians regarding PPE availability really increased the strain they experienced. So this physician said, it felt like in the beginning they told us not to use PPE. Is it okay to trust them when they say it's okay to go into the room without a mask? Finally, this quote illustrates how some physicians really felt when they did not receive that hands-on PPE training. They said, we have these videos that show you how to do it, but there was really no hands-on training. So we just figured out how to do it ourselves. Initially, no one knew the right way and everyone was so scared. Turning our attention to the third S of system, we found that all hospitals in the study cohorted COVID-19 patients, which means really grouping them in the same location, and that physicians felt that really improved workflow efficiency, which makes sense. Instead of having to put on and off PPE for every patient, they just put it on once and got to see everybody at one time. They also felt like there were a lot of obstacles between hospital administrators and the frontline people doing the work, but that in cases when they did involve frontline clinicians as key stakeholders, that actually improved care processes, and they felt like improved patient outcomes because of it. And finally, we found that all hospitals restricted visitors, but that physicians really felt that that policy hurt patients and families. This quote explains how cohorting patients and grouping them in the same location was felt to improve workflow efficiency. So this person said, I think cohorting COVID-19 patients worked well from the standpoint of housing all of them in the same location. Had the patients been scattered all over the place, that would have been really challenging. Just the simple process of donning and doffing, which means putting on and taking off the PPE, everything takes longer with these patients. This quote illustrates how important it was to include the front line as key stakeholders when making decisions about how hospitals would respond. So this physician stated, we are a smaller hospital with a close relationship between those in leadership and the front line. They involved us in all planning, which really increased trust and improved morale. It also allowed us to be more nimble in our responses. And really such open and direct communication between both groups permitted some hospitals to adapt more quickly in the midst of a dynamic situation. And to what Jody was saying earlier, I think this can't start during the middle of the crisis. This sort of culture has to be sought and created in normal, as part of standard operating procedures. Finally, as I mentioned, physicians felt that restricting visitors really hurt patient outcomes through a few different mechanisms. They felt that it hurt their morale when the family wasn't there to encourage them. They felt that it actually hurt measurable outcomes such as the incidence of delirium without patients. So in the ICU, delirium, it's frequent, but it's a bad outcome. It leads to a lot of complications. And family members being there to ground them and orient them is very helpful. So physicians felt that not having family members actually made delirium worse. And in some cases, restricting visitors actually prolonged patient suffering because families were really unable to see the medical reality of what was going on with their loved ones. So for example, this physician stated, there were numerous instances when we were prolonging fetal care because we were unable to establish a relationship with the family. Without the family seeing how sick patients were, they weren't able to process through their grief stages. Physicians also felt that restricting visitors caused harm to families themselves. So this physician stated, the ability to establish a trusting relationship with family over the phone who has never met you and you were talking about things like end of life, it has been next to impossible to establish those relationships. Finally, the last S, or staff. So we found that, not surprisingly, all hospitals experienced staff shortages, including ICU physicians, ICU nurses, respiratory therapists, and that this hurt patient care. Speaking from experience, I can say that when, normally we take care of anywhere from 10 to 15 patients in the ICU. My own ICU is a 16-bed ICU. But in the setting of the pandemic, like we just have gone through the Delta surge, it's been the worst we've actually experienced here in the state of Oregon. We were doubling up to 20, 30 patients are some examples. And for one person to be trying to take care of that many, it's just increases the chances that something will be missed. You don't have time to think slowly. And it feels unsafe and unsettling from the perspective of the providers. Second, a lot of hospitals actually used something called tiered staffing models to expand the reach of physicians and nurses who were specifically trained in critical care. So what this means is taking physicians and nurses who are not trained in critical care, bringing them in to care for critically ill patients, but under the supervision of an ICU physician or an ICU nurse. Also, several hospitals created dedicated treatment teams to improve efficiency. And so what that means, in the ICU, we do a lot of procedures, specifically for patients with respiratory failure. We do something called prone positioning, where we flip them onto their bellies, their abdomens, and let them breathe. It actually improves oxygenation, with some evidence that it improves mortality for these patients. But it's a lot of work and it's unsafe, right? These patients have a lot of tubes and lines in them, and to flip them safely is several times a day is difficult. So several hospitals created dedicated proning teams, for example, to do this. Finally, we found that many physicians experienced moral distress, and that burnout symptoms were quite common. And for this, really, moral distress is defined as the inability to act according to one's core values due to internal or external constraints. So a lot of the moral distress experienced was surrounding visitor policies. So just some examples of this. So this quote, it really illustrates, I think, how the shortage of ICU nurses forced the time of ICU nurses to be rationed. So one physician explained how the allocation of nursing time and respiratory therapy time was very high on the list of resources to be rationed. And they said, if I saw an ICU nurse from our unit, our ICU, I knew I could pick 3 to 4 things for them to do that day because it would be possible. But someone without that training, I would just pick 1 or 2 things. We couldn't push it too far. So it really, care was not advanced to the same degree as it would have been for patients under normal conditions. As I mentioned, moral distress and symptoms of burnout were really common, particularly due to the restrictive visitor policy. So this physician said, restricting visitors was one of the worst things that I've ever seen. Looking back, that was the real nightmare, watching that many people die in the ICU alone. And some clinicians found ways to go against that policy and allow families to go in. So this physician said, frequently we break the rules. This is the biggest strain on physicians. You couldn't save the person and now they're going to die by themselves. I find a lot of us will just let the family go in the room, go in the back door. And I think this really shows how strongly physicians felt that families needed to be there, that they were willing to sort of go against the policy and find a way to let patients go in, potentially increasing risk of exposure to staff, just so that patients could be with their families at the end of life. And finally, many physicians reported symptoms of burnout, in part due to just how sick the patients were, and in part due to the duration of the pandemic. So this person said, my concern about staff well-being is that this fight or flight response can only last for so long. The chronic stress of having to do this over and over again really adds to the strain. So I just want to finish by highlighting some pictures of my amazing colleagues at OHSU. This is our medical ICU, which became our COVID ICU. This is our team. You can see us in PPE with the masks, face shields, and gowns, and we're actually actively proning a patient. So you can see it takes a lot of staff in the room and coordination to flip the patient onto their abdomen. This is the team putting someone on a very specialized device called Ecmo, which stands for extracorporeal membrane oxygenation. It's essentially a heart-lung blood machine for patients whose lungs cannot sustain levels of oxygen that are compatible with life. So basically, it takes the blood out of the patient, takes out the carbon dioxide, puts in oxygen, and we infuse it back into the patient to support them and try to give their body time to heal. And where I live, I I just mentioned that we have gone through our worst surge over the last 6 weeks, and we ran out of Ecmo machines in the entire Pacific Northwest. And it caused, again, another level of distress trying to decide who would get the next one if one became available. And finally, this is a picture of my good friend, Julie, who's one of our local nurses. She was actually interviewed for a news station. And I think this picture speaks for itself about the impact of the pandemic on the front line. So just in summary, pivoting to slightly more positive, I think through this study, we really did identify some things from an organizational standpoint that can help both patient outcomes and frontline clinicians to improve their resilience, help minimize burnout, and hopefully improve outcomes. So the first, when it came to space, I think really defining threshold at which elective surgeries are limited or canceled and incorporating feedback from the front line to make that clear and transparent is helpful. From a stuff perspective, really transparency about availability. I think erring on the side of safety would be prudent if we are to go through this again. Certainly doing what we can to ensure adequate PPE and providing hands-on training was really helpful for frontline clinicians to reduce their anxiety and fear, especially during the pre-vaccine era. From a systems level, cohorting patients was helpful to improve efficiency. Involving frontline staff as key stakeholders is just so important to have that nimble response throughout a crisis situation. For me, both my own lived clinical experience and the findings from the studies I've worked on really make me rethink restrictive visitor policies. I know it makes sense at face value to reduce exposure risk and conserve PPE, but the negative effects on patients, families, and clinicians, I think we need to rethink that and try to re-estimate or actually quantify the risk-benefit relationship. And finally, we found that tiered staffing models and the use of designated treatment teams were really helpful to expand reach of critical care specialists because certainly ICU clinicians are the most limited resource and at high risk of burnout. So in conclusion, we discussed how critical care is an organizational innovation, and therefore ICU organizational structures and care processes really represent a platform for care improvements. We discussed some of the evidence-based practices we use in the ICU today to improve the value of ICU care and how a lot of that's been threatened through the current pandemic. Mainly, we discussed sources of strain and found some potentially modifiable and actionable interventions that could mitigate strain and hopefully improve resilience throughout the pandemic and for future crises. And with that, I want to thank my team of mentors and collaborators and say a big thank you to all healthcare workers, especially I think ICU nurses and respiratory therapists who are certainly unsung heroes throughout this. I think in other countries or in the UK, for example, they might be called physiotherapists, but regardless, I want to thank you to everybody who continues to work hard to care for patients. And with that, thank you for the opportunity. This is a picture looking at downtown Portland from the hospital, which is up on the hill. And I'm happy to answer any questions and look forward to the discussion. Thank you.
Thank you, Jody. Thank you, Jody. Thanks to our speakers for their contributions and for sharing with us their insightful ideas. The floor is now open for questions. So I noticed that Jody has already replied to many questions in the chat. So if I missed some questions and answers from Jody, please feel free to ask the question again now. But well, so the floor is now open for so if you have for questions, and if you have a specific or a question to for a specific speaker, please just make sure that you communicate that. Just raise your hand and I'll
I mean, two of the questions I found super interesting that might be broadly of interest, and there are many here, but the one from Mark about how do you, I'll just read it. Mark Cole, where a network of elements undergird seamless and effective delivery of a service, how best can one ensure that the various agents are able to see everyone in their terrain? And that idea of seeing the whole I think is actually hard in most organizations where they're designed to have you focus attention more within your role, and often the traditional designs are less attentive to other relevant players in your terrain. So, I mean, one obvious answer is to redesign structures to include other parties in the relevant parties in meetings, so you get to hear what their experience is and how it might affect yours. Shared accountability with those other players. But as a starting point, just to start to understand and visualize your interdependence, that relational mapping can be helpful. It's a way people have told me, even in community settings, like in Scotland, where they were working on chronic obstructive pulmonary disease in the community, that once they had done that relational mapping among various agencies in the NHS, they could never not see things that way again. So it might help to shift our way that we see ourselves in a work setting. And yeah, I've also mentioned that Sandra Janoff, with her future search methodology of getting people into the same room to look at and re-envision the system together, could be another interesting methodology for that. So just wanted to put that into the room because I thought it was such a basic question.
Thank you, Jody, for elaborating more on this point. Is there any other questions from the audience? Well, actually, I have a quick question, if I may. It's actually to both Jody and Kelly. So in your talk, you have emphasized, for example, existing structures of, ahead of time structures, or planning or planned redesign, interventions, and also preparation in Kelly's talk for unforeseen contingencies. But during the COVID-19 crisis, we have also seen a lot of organizational improvisation. So my question is, do you have any advice or any experience on how healthcare organizations can learn somehow from improvisation?
Lisa, I'm sorry, Kelly, you want to take that first, Kelly?
Yeah. Thinking of how to answer that. It feels like a lot of what I have seen, a lot of what I have seen is sort of building the plane while you're flying it, is what it feels like. So for example, when we all of a sudden have a surge of patients, we had planned for how to staff it. But then when push comes to shove, and the reality of it is always different. And so you have to be flexible in that. I would say improvising requires really good communication when you're in the midst of it. And I think the biggest thing for me was involving different voices. Hospital administrations making decisions have no idea what it's like on the front ground. And so I think, like, kind of what I got to at my talk is involving people who are living it, and breaking down those silos. I just think that is such a key factor to be able to be informed and create policy that's actually responsive to feedback on the ground, and then constantly iterating it. I think with the changing dynamic situation, I just think communication is so key. I don't know if that totally answers your question. I'll think more about it. And I don't know if Jody, you have anything to add.
Yeah, I think in the same lines as what you're saying. I mean, I used to hypothesize that structures shape relationships. And now what I've learned by watching organizations, in the change process, is that the relationships are very much shaping the ability to design new structures. So I think both in terms of those high quality communicating and relating networks that can help you immediately respond, but they can also help you to redesign your structures as you go. Like, we need a new protocol for how to flip our patients, because we never thought about how many patients would have to be proned. So you basically, it sounds like, came up with a job redesign that involved people whose job it was to do that. And so I do think having those that kind of culture that you called it, or those high quality RC networks, can help you better adapt and improvise on the fly. And then you can step back and say, is this something we want to keep? Is it something that was only useful for the pandemic? But the fact that you can design on the fly is a really important finding. I would just say one other thing in response to Lisa, who basically asked this because she's working with the European community to prepare for crisis, that I'm wondering if we can design some of our structures like shared protocols and team meetings and shared accountability, so that as we realize which other roles may need to be included in this new crisis, how can we just include them in to a structure that's been designed to become more or less inclusive as needed? So it could, that flexibility could be designed into the structure. Maybe there may be people working on that.
Thank you. Yes, that's very interesting and useful. And I think that Michael has something to do about it.
Hi, Michael.
Has something to say, sorry, about it. Yeah.
So I think, I was very taken with Jody's sort of segue about 2/3 of the way through the presentation, where she essentially introduced organizational development as the new topic here, and recognizing there may have been either some deficit in talking about that earlier in her academic training, or there wasn't a deficit out there, but it didn't seem relevant in the form in which it was encountered, perhaps because it was so astructural in its picturing of what to do about anything. So I think it would be good maybe to think about what an abiding interest in matters of organizational development would mean in the light of this kind of research and in the light of the pressures that the practitioner community face. And from that perspective, I think I'd just like to notice maybe something that wasn't said much of, and that is the moves that might be made or not made by people in positions away from the operating and core, positions away from the day-to-day work, strategic apex, technostructure, et cetera. And think about them either as sources of difficulty or sources of practical means to make a dent on these problems. And so I don't think we have a lot of sense of that from the two presentations today for different reasons. But I would imagine that some of the people in the professional community who sit in those kind of roles would be interested in that being thickened up either today or subsequently. And so I don't know, I just throw that out as a general issue. A question would be almost, why is it the case that in these presentations, a mechanism of change, what you might call a leadership intervention, hasn't been spoken of? Okay, I don't think it's just the words. I think it hasn't been there in the discussion, although it may have been, in the background as somebody sponsoring one of these mapping exercises or something, but that's pretty thin. Mm-hmm. So I guess from both of your perspectives, if one wanted to take leadership interventions for good or ill into consideration in these concerns, what might be the first 2 or 3 moves that come to mind?
You want to start, Kelly?
Sure. I guess I guess I can at least comment that the hospitals, in one of my quantitative studies, we asked about sort of more structured questions about hospital leadership responses, and pretty much every hospital created something called an incident command center that made decisions about, I think, sort of like regionally coordinating where patients would go. Had sort of a 50,000-foot view, but the gap between the incident command center and the ICU was huge. So I think closing that gap is important. I think from the leadership standpoint, some other things that I didn't bring up in the talk just because of lack of space, but again, asking what the experience is like and then doing what we can to decrease that burden. So for example, providing like basic needs for frontline was huge. especially early on, people weren't eating. Everything was shut down. There was no access to food, and we were working all the time. And so hospitals just providing food for their workers would have been a huge deal. Childcare was a huge deal, or a place to stay for people who didn't want to bring it home to their kids, for example. So those were things that came out in as like institution level things that could have been done and that weren't, and that people felt, or that sometimes were, but not all the time. And that people felt that was a sort of a lack of understanding from the leadership about what we were going through on the front line. I think stepping back more broadly, I think regionalization is a whole nother topic, and I debated bringing that into this, but sort of, which means transferring critically ill patients to different centers that have space or different expertise. That requires a level of sort of leadership and coordination that I often wondered why that wasn't happening more. Like in New York, when we were hit really early, nothing else was really hit around. So why was New York overflowing so much when other regions weren't, the US hadn't been hit that hard at the beginning? Certain questions were like, why aren't we using that more? And I think those sort of leadership decisions, I hope this sparks continued conversation about regionalization of critical care and how we can more effectively do that. So I don't know if that really answers your question, but those are just some other things that I've thought a lot about that weren't in this talk, but that are out there to be explored further.
Yeah, and I'll share some as well, but I think this incident command center that you mentioned, Kelly, seems to me as an opportunity, if it's designed appropriately and staffed appropriately, to have the whole system in the room to see the whole and adapt under changing circumstances. So in addition to being a leadership issue, it's also major coordinating function. And I know when I studied the airlines, one of the most fascinating parts of my site visits was SysOps, system operations, where they literally did. And there's no reason logistically that can't be done at a regional level, and it sounds like if the ICU felt very distant from your incident command center, then maybe it wasn't sufficiently representative, or the voices of the different parts of the system may not have been sufficiently well represented in the conversations there. But I know some colleagues who are doing a deep case study of that command center at Beth Israel in Boston during the time, to see to what extent were the different voices represented and how did that allow adjustments to happen, and basically relational coordination at a higher level. But this question more broadly, I also had a slide that I was going to share and I didn't, but it's very simplistic, but it's at least an attempt to think about the role of leadership in this when coordination is so critical. And I think I've talked about, the relational coordination between the different parts of the system, and how that might enable us to better partner with the patients and our citizens that we are serving. But the role of leadership could be to use some of those same relationships, not only to connect with the different functions, but I think importantly, to see their role as helping others connect with each other together to see and create the whole. I call that relational leadership, but it's a very, that term has been used for multiple things, but the idea that one of your roles is to help the system see itself and to act rather than obviously the command and control vision, which doesn't work too well under high complexity. But one thing that people have said, my colleague Tony says, that the other role of leaders is to really role model the change that you are advocating. And so it's hard to move to this kind of organization that's networked if leaders have a more traditional view and they act accordingly, like they relate well perhaps to people, but they try to keep people siloed for their own control reasons, and so on. So leaders are critically important from a kind of cultural role modeling standpoint as well, I think, in this change. So I'm glad you asked, and probably next time we'll both mention it.
Thank you, Michael, for your questions, and our speakers for their answer. I think, I'm not sure, is there any other question or comments? I haven't checked the...
I have if I may, I have a question for Kelly and Jody, which is about the relationships that they see between the relational coordination and the standards in health organizations. Because A key role in Kelly's presentation was the ABM, so the evidence-based medicine. So, and we know how difficult may be to use evidence-based medicine in a context of uncertainty. Evidence, of course, needs time to be, produced and diffused. So my question is: do you see any, complementary role, between standards, and how? I mean, my question is how relational coordination can help to, maybe replace standards in context of uncertainty, or maybe help to produce new standards, or to update or to complement the existing standards. Because I mean, one issue is how to use some, standards that are not good in new conditions. So that's my question for both of you.
One of my earliest papers in management science was on this question, and I actually expected, as you kind of implied, that under conditions of higher uncertainty, protocols would be less useful, like clinical pathways, and instead the networks would take over. What I found instead, and it was limited levels of uncertainty in that context, but what I found was the higher the input uncertainty, the differences among the patients, unanticipated differences, the more complexity/uncertainty, the more useful the shared protocols were for achieving outcomes, because they help to support coordination between the roles. And I think it's because, when you have shared protocols, you have at least a starting point for who does what and why and in what kind of sequence and how, and it gives you a kind of a jumping off point for improvisation, so that shared protocols are not necessarily thrown out the window when uncertainty arises, but in fact can be really useful for shaping the process of improvisation. And I wonder if Kelly has any thoughts about that, given your focus on evidence-based.
Yeah, I think it's interesting because throughout COVID, at the beginning, there was like rumor that we should intubate or put people on breathing machines earlier than we normally would. And so everyone was doing that and treating it differently than we normally treat respiratory failure. And then slowly but surely, there was this recognition that led to a lot of variability and we think worse outcomes. And so everybody pulled back in the critical care community and said, take a deep breath. This is respiratory failure, even though it's an unknown virus, but we're going to treat it like we know how to treat it using certain strategies like lung protective ventilation on the ventilator, things like that. And we realized, keeping with the protocol to reduce that variation and doing what we know works for respiratory failure was the right path. And so I agree that actually sticking with some protocols at the beginning and not letting the emotion get the best of you, but stick with what you know. And then when new questions start to arise, things like, COVID patients have a tendency to clot, and the question arose clinically about should we empirically give everybody blood thinners, which we don't normally do. So then we decided to study it, but in the meantime, until a trial comes out, a lot of, so relational coordination is a bit of a new term to me, so I'm learning that, but the relationships with crossing silos and talking to our hematology colleagues and picking up the phone and talking to people in New York and Chicago and crossing those silos both institutionally and across fields was really, really helpful. So sort of leveraging the capital that you have in that sense was really, really useful to answer some of those questions and kind of as a community come together and decide how we were going to respond to some of these. So I really agree that keeping the protocols can be really useful as a floor, like a grounding practice to get everybody on the same page and minimize variation as much as possible. And then the new questions that arise, you talk to each other and you ask for help. And slowly but surely you start to get some answers through trials and things. Yeah.
Thank you very much. I think there is 1 minute left, so we have to close our webinar. Probably there is the announcement of the next webinar.
I'll probably not announce the next webinar. We have a regular, basically every second Thursday, we have a webinar on the Organizing for Good, but we also have the annual conference coming up by the end of this month. So you should go to the organizational design community where you can see the activities. And on behalf of the organizational design community, I would like to thank the speakers and the discussions and all the participants. And we are really grateful that you are here. And I think that we had a very, very good discussion here. Very good presentation. So thank you very much. We really appreciate that you participate in the Organizing for Good campaign. So thank you very much.
Thank you.
Thank you.
It was